We go on to the next presentation, last presentation for Dr. Rajesh Fogla, which is a recorded video because he couldn't change his flight timing. And his talk is on complications post endothelial keratoplasty. I would be very obliged if the expert panel take up some relevant point and explain it. Increase the volume.
I have no financial interest to disclose. Endothelial keratoplasty, DSEK or DMEC, is currently the preferred surgical technique for managing endothelial disorders. Successful management of post-operative complications is essential to improve the surgical outcomes. This presentation will cover some of the common complications and its recommended treatment. One of the common complications that we see is graft detachment. It occurs more frequently with DMEC than with DSEK, usually seen in the first 1 to 2 weeks post-surgery after the air or gas has been completely absorbed. Why it occurs? Due to either inadequate air or gas tamponade, hypotony, interface debris or irregularity, external manipulations such as rubbing of the eye, poor endothelial cell function due to excessive manipulation of the donor or its reverse placement. Patient typically has decreased vision, persistent corneal edema, and partial or total separation of the donor disc. The diagnosis can be confirmed on slit lamp examination and by performing a corneal anterior segment OCT. Management usually involves rebubbling with air or gas bubble, followed by proper head positioning. And this is usually indicated in DMEC if there is progressive separation or the edema involves the central area or more than 30% of the surface area. How can you prevent it? By optimizing your surgical technique and avoiding excessive manipulation of the donor graft and ensuring that you have adequate tamponade for the initial postoperative period. The other common complication is intraocular pressure spikes. This can occur in the early or late postoperative period. Commonly in the early post-op, often it occurs because of pupillary block, because of the air or gas going behind the pupil and then resulting in peripheral anterior synechiae and blockage of outflow. Patient can be a steroid responder, or there can be pre-existing glaucoma, or especially in conditions like ICE syndrome. With severe rise in pressure, you can have pain, redness, headache, vomiting, decreased vision, or sometimes the patient can be asymptomatic as well. The management involves use of topical or oral medications to reduce the intraocular pressure. And in prevention, yes, proper surgical technique, either keep the pupil dilated in the postoperative period, examine the patient 2 hours post-surgery, or intraoperatively you can perform an inferior peripheral iridectomy, which ensures that you don't get a pupillary block. The other complication that we are worried about is infection. It can occur because of viral, bacterial, or fungal etiology. If it occurs very early in the postoperative period, it could be because of donor contamination, and usually it's bacterial. In the late post-op period, you can get interface infections, which are typically from Candida, or it can be from a viral etiology as well. Typically, the patient will present with pain, redness, decrease in vision, and on slit lamp examination, you can observe these corneal infiltrates. You may require to do a microbiology to establish the organism and provide the appropriate antimicrobial therapy. Often it means that you have to remove the donor disc from the eye to eradicate the infection completely, although for small interface infiltrates, intrastromal antimicrobials have been attempted to try and resolve the infection. Again, proper surgical technique, avoid venting incisions, give adequate antibiotic prophylaxis, and always evaluate the donor tissue once you receive it from the eye bank for any change in the color of the medium or turbidity. Graft rejection is much lower compared to penetrating keratoplasty. It's the lowest with DMEC compared to DSEK. Again, the symptoms could be a decrease in vision, light sensitivity, pain, redness, and on slit lamp examination, you can see corneal edema and keratic precipitates. Often they are limited only to the donor disc, And if you see the keratotic precipitates across the entire cornea, you have to differentiate from a viral endotheliitis. Sometimes epithelial ingrowth can also mimic a similar clinical picture, and interface opacities with keratotic precipitates. Also, you need to think about infection. Once you diagnose that it's rejection, yes, the mainstay of treatment is using topical and systemic steroids. You may need to start the patient on immunosuppressive therapy for preventing future rejection episodes, and obviously these patients need closer monitoring than your routine cases. Especially adequate immunosuppressive therapy should be given in high-risk graft, such as patients with multiple transplants, systemic disease, or previous episodes of graft rejection. Primary graft failure is rare, but it can occur in the learning curve. Often it's due to a reverse placement of the donor graft or due to TM detachment, decreased vision, and persistent corneal edema, which is not resolving. It can be confirmed by looking at slit lamp examination and doing serial anterior segment OCT. If the graft does not clear for 8 to 12 weeks, you may have to consider exchanging the graft with a fresh donor tissue. And preventing, yes, you get good quality donor tissue from the eye bank with at least cell counts which are more than 2,400 or 2,500, and stamp the donor tissue on the stromal side to ensure correct orientation. Cystoid macular edema can occur in about 8 to 12% of cases undergoing endothelial keratoplasty. It can be pre-existing or it can occur in the postoperative period. Again, this can be when you have a clear graft, but the patient vision doesn't improve appropriately. You have to perform a macular OCT, and if it's present, then you can treat with either topical NSAIDs, or sometimes you may have to refer to your retinal colleague for intravitreal or posterior subtenon steroids. And controlling the inflammation in the postoperative period may help avoid this problem. So basically, in conclusion, it's important to discuss with your patient undergoing endothelial keratoplasty about all these postoperative complications. Important to monitor the patient appropriately in the early postoperative period and intervene if you notice any of these complications. Future research, yes, it may reduce these complications by introducing newer surgical procedures such as cell-based therapy and newer diagnostic techniques like the use of femtosecond laser and the intraop OCT may help prevent some of these postoperative complications. Thank you. Thank you for a patient hearing.